Good evening, everyone, and thank you for joining us for our third Hexarad educational webinar. This evening, we're joined by Dr. Uzoma Nnajiuba, who's a consultant head and neck radiologist working at Aintree Hospital, which is the tertiary head and neck centre for the Mersey region. He's going to talk to us about acute imaging of the neck. He's also my Radcast co-host, so thank you very much for helping me out with this. I'll pass you over to him now.
So yeah, hi guys. So I'm going to just give you a fairly basic overview of acute neck imaging, try and give you some tips for when you're reporting cases sort of acutely. So yeah, let's crack on. So just starting with some basic anatomy of the upper aerodigestive tract. So it's divided into various sections. You've got your nasopharynx, which is behind the nasal cavity. So you have your carina at the back, and then posterior to that is the nasopharynx. And that extends from the skull base down to the level of the hard palate. Below that is the oropharynx, which is from the level of the hard palate down to the tip of the epiglottis, or sometimes the hyoid bone. Inferior to the oropharynx is the hypopharynx. And that extends down from the epiglottis to the esophagus, and then anterior to the hypopharynx is the larynx, and that's from the epiglottis down to the trachea. Something that people sort of get stressed about with head and neck imaging is the anatomy, particularly deep neck spaces. Particularly with acute imaging, it's not something that you really want to be obsessing over too much. It's certainly it's more relevant to sort of head and neck lesions rather than acute infections, but it's a good idea to have. It's good to have like a basic understanding of the neck spaces and their relevance. So you've got your head and neck anatomy is often divided into the suprahyoid and the infrahyoid region, because the hyoid bone is a very important attachment of lots of different muscles and fascial planes. So you have suprahyoid neck spaces, and you have infrahyoid neck spaces, and then you have some neck spaces which traverse both the suprahyoid and infrahyoid neck. Sorry, I've got a bit of a cough. So I remember when I used to report neck images, I'd always go on Radiopedia and get this up and try and work out exactly what space a particular pathology or infection was in. As I say, it's less important in acute infection. You just describe stuff in terms of general regions rather than obsessing over the space. But if there is one thing that you should probably remember about deep neck spaces, or one landmark which is good to have to be able to recognize, it's the parapharyngeal space, which you can typically find because it's the fatty triangle in the suprahyoid neck. And that's a good space or landmark to be aware of, because the parapharyngeal fat is bounded by lots of other neck spaces. So lateral to it, you've got your parotid space. Anterior lateral to it, you've got your masticator space. Medial to it, you've got your pharyngeal mucosal space. Posterior medial to it, you've got your retropharyngeal space. And posterior to it, you've got your carotid space. And so if you have a lesion or an abscess in the deep face, it's good to try and spot where the triangle of the parapharyngeal fat is, and see where it's being displaced, because then it will tell you in which space a particular infection or lesion is originating. So say you have like a big masticator space lesion or abscess, it will displace the parapharyngeal fat posterior medially. If you have a parotid space lesion or deep abscess, it will displace the parapharyngeal fat medially. So that's a good landmark to sort of be aware of. And then you also have your infrahyoid neck spaces, which are less relevant mostly for acute neck infection. Most of the action happens in the suprahyoid neck. So in terms of your neck infections, the spaces where stuff is going to originate are in your pharyngeal mucosal space, so particularly in regard to tonsil infections and peritonsillar abscesses, your masticator space and with odontogenic infection, Your parotid space with parotid sialadenitis, submandibular space with submandibular sialadenitis, and then you've got your retropharyngeal space and retropharyngeal abscesses. Another thing to sort of be aware of is that even though a process may start in one space, a disease, whether malignancy or infection, can spread to other spaces at the same level, or extend craniocaudally through spaces that traverse or transcend different levels. So there's a couple of spaces or a few spaces which extend from the suprahyoid through the infrahyoid neck, particularly the carotid space and the retropharyngeal space. So if infection gets into those spaces, it can sort of spread out of the head and neck into other regions, which is important to be aware of. So when you're protocoling a acute neck scan, do a contrast enhanced CT neck with the upper thorax included, because you want to see if infection spreading into the thorax, and about 100-second delay is sort of typically what we recommend. So a nice checklist to sort of think about when you're reporting an acute neck scan is the 3 C's. So you want to look for the cause of the infection. So it might be a bit overwhelming. You'll have like lots of edema and nastiness going on in the head and neck, but you really want to try and see if you can work out the epicenter of the infection, and it's going to be coming from one of these sites. So a tonsil, retropharyngeal region, the teeth, a salivary gland, a sinus, or the temporal bone. So that's sort of the first bit. Try and work out where it's coming from. Then you want to assess if there's a collection, and you want to describe the size of the collection and where and the extent. And then complications like airway compromise. Is it extending into bones, or is it spreading into other areas outside of the head and outside of the neck? So intraorbital extension, intracranial extension, or mediastinal extension. So the 3 C's is a good checklist to sort of have in mind when you're reporting these scans. So we'll start with the most common type of infection, which is involved in the tonsils, so particularly a peritonsillar abscess. Peritonsillar abscess is what we sort of know clinically as quinsy. This is the most common deep neck infection or abscess. It will present with atalgia, trismus, and voice change, and it's managed with incision and drainage. So peritonsillar abscesses are the common ones, and they basically are a result of an abscess forming in between the parotid capsule margin and the pharyngeal constrictor. I don't know if you can see my mouse, by the way. Hopefully you can. Yeah, and pharyngeal constrictor, so they sort of develop in that space and displace the tonsil medially. Far less common than is intratonsillar abscess, where it actually develops in the tonsil. You have milder symptoms, and they're treated conservatively with antibiotics, presumably because they're not sort of trapped in a compartment. It's just within the tonsil, and it can relieve itself. So yeah, with peritonsillar abscess, you'll see your tonsil. So it's really good to look for your tonsil, and you'll see it displaced medially. You'll have you may have an abscess, so you're looking for a low attenuation area with rim enhancement, as you all know. I tend to sort of measure the Hounsfield units. I had a Max friend who was sort of taking the mick out of radiologists because we always say that there's a collection, and then when they go in, it's often dry. So that sort of scarred me. So I always like measure the Hounsfield units and actually try and look for fluid rather than just edema. And like I use a cutoff of like 30 to 40. If it's like less than 40, I'm confident it's an abscess rather than just edema. But I mean, regardless of what the Hounsfield units was, if you see this appearance, you're going to call an abscess. And yeah, you'll have stranding in the adjacent spaces. So I've got an example of a peritonsillar abscess. So you can see I've measured the Hounsfield unit there. See this sort of well-defined, no attenuation area with rim enhancement. If you look, you can see the tonsil displaced inferior medially. It's easier to see on the coronal. So this is an abscess in the peritonsillar region between the tonsil and the pharyngeal constrictor. Often when people report these, they call them parapharyngeal abscesses, but it's not a parapharyngeal abscess because the parapharyngeal fat, that little triangle of fat, is displaced laterally. It's got a bit of stranding in it, so it is a peritonsillar abscess. You'll see stranding, sort of, or edema down the pharyngeal wall, and there's quite prominent reactive lymph nodes in this case, and you can get like really big lymph nodes in acute neck infections. If it's like a fairly young patient, it's obviously infection, then I'd just call these reactive lymph nodes, even though they're fairly chunky. But if it was an older patient and I was feeling a bit more cautious, I might say that it'd be good to just do an ultrasound after the acute admission has resolved to make sure that the nodes go away. But this is a young patient, and these are just some very chunky reactive lymph nodes. So that's like a nice peritonsillar abscess. In terms of sort of the complications, so airway effacement is a big one. Extension into the retropharyngeal space, whether that's just the edema or actually an abscess. Then extension or involvement of the carotid space, which can lead to IJB thrombophlebitis and a syndrome called Lemierre's syndrome. Lemierre's syndrome is IJB thrombophlebitis secondary to deep neck infection, and the pathogen that typically causes it is Fusobacterium necrophorum. Once the infection gets into the carotid space and causes the IJB thrombophlebitis, it can then travel to other parts of the body and go inferiorly into the lungs, and you get septic emboli, or go superiorly into the brain, and you get like cavernous sinus thrombosis as you have here. So that's a complication. If you have like a big neck infection, just make sure that the IJV is enhancing. On to next kind of abscess, so like a retropharyngeal abscess. So I mean they're more common in peds, but starting with adults, because they're generally like the classic retropharyngeal abscesses. So these happen, patients who are at risk of these, patients who are immunocompromised and have other infections which then spread into the retropharyngeal space. Also trauma and foreign body ingestion leads to these, but they're more common in the pediatric population, and they're actually generally caused by lymphatic drainage of infection from other sites in the head and neck to retropharyngeal nodes. So typically these start as suppurative lymph nodes rather than like proper abscesses originating in the retropharyngeal space, and then they sort of burst and become just like a true retropharyngeal abscess. It's a suppurative lymph node rather than like an abscess, although it's kind of academic, the distinction, but there is no septum that separates both sides of the retropharyngeal space. So if it is a lateralized nephrotic or suppurative lesion, then it's a suppurative node. But eventually it's like becomes indistinguishable from an abscess. Sites of sort of the initial infection, which might spread to or drain to the retropharyngeal region, to the nose, so it might be otitis media or sinusitis. So the retropharyngeal space is a very it's a space that you're wary of in head and neck infections, because it's as you probably know, it's a route that infection can spread down into the mediastinum. So it's not actually the retropharyngeal space that the infection descends down into the mediastinum through. It's the danger space, which is immediately posterior to it. And there's only a very thin layer of fascia that separates the retropharyngeal space from the danger space. So if you have infection in the retropharyngeal space, it gets into the danger space, and then it can descend down into the mediastinum and cause mediastinitis. Which is why, as you all probably know, you have to do the image of thorax when you have an acute neck, just to make sure that you don't miss infection spreading down there. So I just have an example of I think it's the same one in the presentation, but yeah, you can see that this is a suppurative lymph node, or you'd just probably call it a retropharyngeal abscess. And there's stranding sending down the oropharyngeal wall, and you can see the stranding in the retropharyngeal space going down, and you'd want to follow it all the way down in that space and make sure that you don't have mediastinitis, which you don't have in this case, but that's sort of what you want to make sure that there isn't infra-extension. So yeah, this is a suppurative lymph node. It's difficult to say where the infection originated here. There's a lot of stranding in the pharynx, so maybe it was pharyngitis, although that could just be reactive from the retropharyngeal abscess or suppurative lymph node. Condition that is useful to be aware of, which can mimic retropharyngeal abscess, is calcific tendinitis of the longus coli. So this is an inflammatory condition. It's caused by an inflammatory response to calcium hydroxyapatite deposition, which forms in the longus coli muscle and is typically found just anterior to C2 or near the C1-C2 articulation. And clinically, it can present just like a neck abscess or retropharyngeal abscess. So they'll have neck pain, fevers, and odonophagia. So it's just something to be aware of, because it can really mimic a retropharyngeal abscess, but it's treated completely differently. So it's treated with analgesia and non-steroidals. So So it's good if you can recognise it and spare the patient an incision and drainage. So this is what it looks like. You'll have a fluid collection in the retropharyngeal space, and you'll have your calcification, which is typically sort of around the C1, C2 articulation. And if you see that appearance with retropharyngeal sort of fluid, then be confident to call it calcific tendinitis. They say that there is no room enhancement associated with these, but you can get room enhancement, as I'll show you in a case I have, but it's definitely less than a true retropharyngeal abscess. So here you can see, so this patient presented with symptoms of query retropharyngeal abscess, and you can see there's this edema in the retropharyngeal space, but there's not much rim enhancement, but there is maybe a bit of rim enhancement on the sagittal. So you could be forgiven for saying that might be an abscess, but then if you look at the C1, C2 articulation, you have that you have that amorphous calcification there. So this is like your typical calcific tendinitis of the longus coli, but it looks a lot like a retropharyngeal abscess. Like that. So next, odontogenic infection. So the imaging features that you might see in a dental infection. So on an OPG, you're looking for like carious teeth and periapical lucency. So the caries aren't really obviously they predispose the patient to having abscesses. They got dental disease, but the abscess is happening in the actual mandible in the periapical periodontal region. So you're looking for periapical lucency. So even though you can't see a massive caries in this tooth here, there is a periapical lucency. It's impossible to say whether that's like an abscess or whether it's just some chronic dental infection. Here you've got another grossly carious tooth and a large periapical lucency. So if a patient presents with and they're querying a dental infection, you probably sort of describe these lucencies, but that's the biggest and that's the most carious tooth. So you'd be thinking that's the most likely site of the infection. On a CT, so you'll see like a periodontal lucency, you'll see sclerosis in the bone, which indicates sort of chronic dental inflammation. If you compare it to the other side, you see periosteal reaction, so all of your sort of signs of bone inflammation and bone infection. And you'll often see an extraction socket. So the patient, when they've been scanned, will often already have had the tooth out. So you'll just see an extraction socket. If it's fresh, it will have like soft tissue attenuation and some gas nodules within it. So look out for that. In terms of the development of abscess, so yeah, these can definitely develop into abscesses. You have abscesses forming in sort of the perimandibular region, and sometimes you'll see a perforation in the cortex of the mandible through which the infection is seeping into the sort of perimandibular region and the floor of mouth. The infection can spread superiorly into the infratemporal fossa. That's still the masticator space, or spread inferiorly into some sort of more inferior spaces, so spread into the submandibular space. A complication of odontogenic infection or any deep neck infection, but most commonly odontogenic infection, is Ludwig's angina. So this is rapidly progressive cellulitis of the floor of mouth, secondary to odontogenic infection. And so the floor of mouth is sort of this region. You have your mylohyoid sling, which basically holds your oral cavity structures in place, and then you have like your sublingual spaces, your extrinsic tongue muscles. So it's basically this region that's technically your floor of mouth. And basically the infection will start in the teeth and then spread and involve this whole region. But you can also get it from tonsillitis, sializonitis, epiglottitis, and other deep neck infections. I'm just going to have a drink of water. So what you're looking out for in Ludwig's angina is just more extensive stranding throughout the floor of mouth and the submandibular region and the submental region. You might see a collection, and this sort of edema in the collection can elevate the tongue and displace it superiorly and posteriorly and cause airway obstruction. And then you might see gas locules related to the infection if it's developing necrotizing fasciitis. So got a case here. You can see in this situation you've got clearly an odontogenic infection. You've got this large periodontal lucency around this distal molar. You've got some sclerosis in the bone. It's hard to see. The other side's pretty sclerotic as well because it was probably
Uzi, you've muted yourself.
Yeah, I'm just gonna. There we go.
Sorry, I forgot to unmute myself. I'll go back to where was I speaking up to?
It was just as you were talking through the case.
Yeah, just 10 seconds or so.
So okay, the case. Okay, so back where I was. Okay, so you've got this
You've done it again.
You've got this odontogenic. It's going so well. So you've got this infection, around the distal molar. You've got this periodontal lucency. You've got sclerosis of the bone.
Done it again.
It keeps on muting. I don't know why it's doing that. Okay, I'll just try. Okay, so you got this periodontal lucency around this distal molar. You've got sclerosis of the bone. And then you have this lots of inflammatory chains, this stranding and edema in the floor of mouth, extending into the submandibular space and the submental region. And you've got these gas locules extending up. This is still in the masticator space. You can see in the coronal how extensive all the gas is. So this would be what you'd be calling Ludwig's angina. Right, so acute silaginitis is generally ascending bacterial infection of the salivary glands. It's usually due to an obstructing stone. And most of the stones, 80% of the stones, form in the submandibular duct and relate to the submandibular gland, and that's thought to be due to the viscosity of the saliva. So what you'll see is you'll have an edematous submandibular gland. You'll see sort of curvilinear low attenuation areas extending through the gland, and it'll be a bit bulky, and you'll have stranding in the adjacent submandibular space, and you've got thickening of the overlying fascia. If you see that appearance, then the first thing you want to do is go straight to look for a stone along the course of the duct in the floor of the mouth. So the submandibular duct, which you can see nicely here because it's dilated, runs sort of between the mylohyoid muscle and the hyoglossus muscle in the sort of sublingual space, and that's a stone there. And then you can also get an abscess within the submandibular gland as a result. So here's an example. You can see the submandibular gland is edematous and swollen. You've got a bit of stranding around it, and you've got thickening of the fascia. And then the first thing you want to do is, okay, there's probably a stone causing this if it's acute. So you go straight to the floor of mouth, and you can see a stone in the anterior aspect of the duct just before it opens, sort of in the floor of mouth. The duct is not massively dilated here, but this is definitely a stone in the distal duct. So that's basically what you want to be looking for. Same goes with the parotid gland, so a calculus within the duct causing acute parotid silaginitis, and you can see the duct there more distally as it's inserting or entering into the mouth next to the upper second molar. Now finally onto temple bone infection. So mastoid and middle ear effusions are quite common on imaging. We see them all the time, and they're very non-specific. And otitis media and mastoiditis are clinical diagnoses. The sort of things you want to be looking for that might make you more concerned or might look harder, just that this isn't just a bit of mastoid or middle ear fluid, or if it's very asymmetric, if there are bony changes, particularly erosion, if there's surrounding soft tissue changes, and if you see some of that stuff, you especially want to check the nasopharynx, because your middle ear drains into the nasopharynx via the eustachian tube, and if you have something in your nasopharynx obstructing the eustachian tube, then you'll get a unilateral tympanomastoid effusion. terms of like scanning in mastoiditis, the reason you do that is to look for complications. As I said, it's a clinical diagnosis. So if you're going to do that, give contrast. And some of the complications of mastoiditis you might see are sort of erosion of the septations in coalescent mastoiditis. You might see a venous sinus thrombosis or abscesses or empyemas. So it's reasonable to do a CT if they're querying any of these complications. There are certain conditions which are related to mastoiditis or sort of develop as a result of it, or have similar imaging features. So you've got necrotizing otitis externa and apical petrositis, sometimes called petrous apicitis. So necrotizing otitis externa is a severe infection of the EAC, and it spreads to the surrounding soft tissues, deep neck spaces, and then leads to sort of skull-based osteomyelitis, and can have intracranial complications as well. The history is always very important with these patients. So they're typically diabetic, elderly diabetic patients, and 98% of the time it's caused by Pseudomonas. And it can lead to a variety of complications. So intracranial complications, it can erode away the TMJ, often causes a facial nerve palsy, and venous sinus thrombosis. So the imaging features you're looking for, so you'll have lots of information, soft tissue thickening and stranding in the EAC, complete stenosis of the EAC. Bone erosion is sort of the main thing you're looking for to make you think this is necrotizing otitis externa. So there's actual erosion of the bone. So it might be the mastoid cortex or the septations, or it could be the margins of the TMJ. It could be the facial nerve canal. So you can see here there's lots of erosion in the temporal bone. That's what that area should look like, and you can see the facial nerve canal descending through the temporal bone, and here it's completely eroded. So this patient would typically have a facial nerve palsy. So if you see sort of this stranding and bone erosion in a diabetic patient, then it's probably necrotizing otitis externa. Another similar condition is apical petrositis. So this is generally, it results from infection in a pneumatized petrous apex, or can be sort of deep extension of otomastoiditis. And these patients will present clinically with acute otomastoiditis, deep facial pain, and an obtusum nerve palsy. So that's called Grodenigo syndrome. The sixth nerve, your obtusum nerve, runs through the petrous apex in Dorello's canal. So if you have apical petrositis, then it can lead to a sixth nerve palsy. So what you're going to see is you're going to see nasopharyngeal soft tissue thickening, and you're going to see a pacification and erosion of petrous apex, air cells, and bone erosion, and you'll often see a tympanomastoid effusion. Now, obviously, if you have these sorts of appearances with lots of opacification, soft tissue thickening, and erosion, you want to be thinking, could this be something else other than infection? Namely, could it be a malignancy, so like a nasopharyngeal carcinoma? So you can see how similar that malignancy looks to this infection. They almost look like identical cases. So if you do have a mastoid effusion with bone destruction and maybe some nasopharyngeal soft tissue thickening, recommend an MRI because you want to rule out malignancy, and also it's easier to sort of demonstrate some of the typical changes of some of these infective processes, particularly necrotizing otitis externa, which has a very typical appearance on MRI. So this is just sort of as a matter of interest. So this is what NOE looks like on MRI. So you have your sort of EAC thickening enhancement, and it very characteristically diffusely spreads into the deep neck spaces. So this is in the masticator space, and you've got some enhancement in the petrous apex. So there'll be some skull-based osteomyelitis going on here. This is apical petrositis. Got this thickening in the nasopharynx, and again, there's some involvement of the clivus. Whereas this is a nasopharyngeal carcinoma, so it looks like a much more more defined sort of matte soft tissue lesion and infiltrative process. But to be honest, this could easily be a malignancy as well. So often there's no way of distinguishing between particularly apical petrositis and a nasopharyngeal carcinoma other than biopsying it. So in summary, with neck infections, remember the 3 C's. So you're looking for a cause, looking for a collection, and then looking for any sort of complications. Spaces, don't obsess over spaces in sort of neck infections. Describe stuff in terms of regions, so sort of the submental region, or you can say parapharyngeal region, perimandibular region. Don't obsess about sort of getting the anatomy spot on. Mastoiditis is a clinical diagnosis. You scan for complications and give contrast. And if you have a unilateral mastoid effusion and bone erosion, make sure you check the nasopharynx and recommend an MRI to make sure you're not missing a malignancy. And that's it.
Amazing. I don't know if the audience have any questions. That was a really nice comprehensive overview. Uzoma, thank you so much. But now we can open up. If anybody has a question, you can either raise your hand or you can just come off mute and ask the question. Oh, I think Amy's got a question. Let's see.
I put it in the chat just because I'm on a train, so I've got a bit of background noise. But if you can hear me, I just was saying, Uzi, that was really great.
Thanks,
I really enjoyed it. The CT neck is always something that scares me, and you did make it much simpler. My question is actually not around CT neck, but as incidental findings on CT heads. Lots of general radiologists will mention sinus disease, and lots of head and neck and neuroradiologists will say don't mention it, it's never relevant. And so I'm assuming, based on your talk, if it's asymmetrical, we probably should be mentioning it then. You know, sometimes on your CT head request, you don't know if the patient seems septic, and I guess the clinicians are scanning quite quickly now. So if someone's kind of come in off legs, you won't necessarily get directed to a sinus infection. What would your tips be for sinuses and infections on CT heads?
So with sinuses, just like with temporal bones, there are certain features that make you think this is more than just an effusion. With sinuses, marked asymmetry is a particular you should look harder, but it's not a specific sign, and lots of patients will have asymmetric sinus disease. If you have a pacification of sinuses that looks like it's in a drainage pathway, so for example, if you have a pacification of the maxillary sinus, the frontal sinus, and the anterior ethmoid on one side, and particularly if it's like only those, then that suggests that you might have a lesion obstructing the osteomeatal unit, which is where they all drain to. So if I saw that, that's called an osteomeatal unit pattern of obstruction or a pacification, then I'd recommend ENT review and tell them to look at the OMU, because they can see the OMU. Likewise, your posterior ethmoid and your sphenoid sinus both drain via the sphenoethmoidal recess. So if I had unilateral pacification of just those two on one side, I might think, is there a lesion obstructing the sphenoethmoidal recess? The surgeons can't see that, so you'd probably recommend an MRI in that case. Apart from that, just your standard things. So if you have expansion, again, not necessarily doesn't mean it's malignant, but it indicates that it's normal sinus disease doesn't cause expansion. So there might be something blocking something, even if it's benign. Even if it's just benign mucosal thickening, so that could lead to a mucocele. So you might want to do an MRI in that case, or at least recommend ENT review. And if you have bony changes, so erosion, so any bone destruction, that is absolute red flag. And that needs an urgent sort of ENT review, and they'll get an MRI. Hyperdensity in sinuses is something that people often sort of comment on and say, could that be fungal? And it might be fungal, but it could just be sort of inspissated secretion. So it's more than hyperdensity. If you see like really dense, almost like metallic bits, focal dystrophic calcification within a sinus, that can indicate fungal sinusitis, and you can recommend an ENT review, although these patients are often like old and it's chronic, so I'm not sure they're that fast. And then if you have any changes beyond the sinus, so if you had like maxillary sinus opacification or ethmoid sinus opacification, and you saw some shining in the orbit, or you saw some shining in the anterior skull base or something like that, then again, you might, then that would alarm you. So you're just looking, so just standard mucosal thickening, I don't really comment on, to be honest, but you're looking for anything, so asymmetry, expansion, destruction, and sort of changes in adjacent structures. And if it's like in a pattern of a drainage pattern.
That's so helpful. Thank you so much.
Nice.
Is there anybody else from the audience that has a question? I think some people are asking whether it's recorded. Yeah, this is recorded, so we're going to be sharing this afterwards. Jamie, I don't know if you have anything you want to touch on or close with.
Oh, thank you very much. That was a really, really interesting talk. I'm sure everyone found that really useful, and we've got plenty of interesting people wanting to watch it back. So yeah, clearly a big success. So thank you very much for doing that for us.
No worries, apologies. I was like holding in coughs throughout it and sniffs, so and then the mic issues, but it's cool. Hopefully you found it useful. Yeah.
No worries. Thank you so much. I think if there's no other questions, then we might be able to just finish a little bit early. So thank you everybody for joining.
Thanks, Susie. It was brilliant.
No worries. Thanks, guys. See you soon.
Bye.
Cheers.
Thanks, guys. Bye.
Bye.